Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Hello, everyone, and welcome to today's MDT, which is a part of the ongoing academic activities of the Sudanese Society of Breast Imaging. Since our establishment in 2018, we have been dedicated to early breast cancer detection in our beloved country, Sudan. Over the years, we have worked closely with healthcare institutions, voluntary organizations, universities, and other specialties to ensure that patients receives timely diagnosis and appropriate treatment. And despite the challenges brought by the war in Sudan, our commitment to this mission has never wavered. We've resumed our efforts by organizing free clinics in safe areas and continuing our scientific and academic activities remotely. It's our pleasure to welcome you to today's SSBI multidisciplinary team case discussion. Please join me in welcoming Dr. Wala Zubair, a consultant radiologist and breast imaging specialist at University Hospital of North Midlands Trust, and Mr. Ghassan Al-Amin, consultant oncoplastic breast surgeon at Sherwood Forest Hospital Foundation Trust. He is also the breast unit clinical audit lead and the oncoplastic MDT lead. Thank you both very much for your time today. And the mic is yours now, Dr. Wala.
Thank you very much for this generous introduction. So I'm going to present July MDT meeting. Here you are. We will start with, we have 8 cases, different pathologies and challenging cases. So the first case is, we have a 63-year-old female presented to the 2-weight clinic with right breast lump, and suspicion was fat necrosis, hematoma, or other pathology, because on examination, the clinical suspicion was P2, which is benign on examination. And this is the mammogram MLO views of both breasts. If any one of the presenters want to share in description, you are allowed. And if you want to go, if you want me to go through the images and then let any one of the registrar to describe, that is your decision, Dr. Rabab. So, so the MLO and CC views showed increased density in the right breast, right upper inner breast. And there is calcification, which is not very well seen in these images. This is the ultrasound of the same area, which is in the right upper inner quadrant, which is showing hypoechoic irregular mass, mostly 5 centimeter in maximum dimension. This is the axilla scan of the right axillary scan, which showed a lymph node with focal cortical thickening. So, so the imaging findings already described with the images. I will go to the next, because I have needle core biopsy results. So the results of needle core biopsies was LB5 on the right breast, and B5 on the right breast, and LB5 on the axilla, but I will show you these MRIs first and then go through the pathology and images. So pre-NACT MRI showing extensive disease in the right inner breast. You can see the video very well?
It's clear, yes.
Okay. So there is also lymph nodes with cortical thickening, at least 3 on this MRI. This is the first. So post-NACT images showed complete response. In the right breast and axilla. So the treatment was neoadjuvant chemotherapy, and then surgical plan was mastectomy with sentinel lymph node biopsy. So actually 7 nodes retrieved, and this case was a pathway of ANTEC, which is a randomized study investigating whether prompt axillary treatment and its associated side effects can be avoided in patients with no residual cancer in the lymph nodes after chemotherapy. And Dr. Ghassan can have another input forward. So the histopathology of the wide local excision was tumor bed scar 40 millimeter in maximum dimension, deep margin 5 millimeter, all other margins more than 10 millimeter. Single duct with atypical proliferation and giant cell, no clear residual in situ components. Axilla, 7 nodes retrieved, and no one of the nodes show metastasis because complete radiological response after neoadjuvant chemotherapy. So conclusion, no residual invasive disease or nodal metastasis, and adjuvant therapy with radio and or endocrine therapy depending on receptor status. That was case 1. Do you want me to go for case 2, or you want to have any discussion in this case?
I think we better take them case by case, isn't it? Just to discuss the cases
Yeah.
and input from people as well. So, did you say anything, Dr. Rabah?
قلت لها مشيتي سريع. ولا رأيكم شنو يا شباب؟ كده كويس معاكم؟
لا على طول انتوا you have your own
لا دقيقة، أنا أشوف الحضور يا شباب. Is it okay to go like this ولا؟
والله كان شوية سريع.
A little bit slower.
Okay.
We can go over the case again. Like, you can go back to the slides and I'll talk about the case and you can answer any questions, Dr. Wala.
أيوة.
Okay.
So because this one is really, it's a good case and it raises many points as well. So starting from the beginning, like this lady is 63. Of course, in the triple assessment clinic, you'll need to know how fit she are, has past medical history. Specifically, I noticed that it's the impression of the examiner said query fat necrosis. So was there a trauma or not? Or hematoma. So probably there was a trauma since they querying fat necrosis or hematoma. However, this sound like there was a palpable lump there. One of the important areas that we can't take what the patient says for granted. Like this patient, if she said, many patients, they are hoping this is because of a trauma. So they'll tell you, I felt this lump after something hit me here. And it's very dangerous when we base our suspicion on the patient's own words for a hopeful patient. Like in this case, probably the patient came and she said, I had a trauma and the lump appeared. And based on that, whoever examined this patient put query fat necrosis, query hematoma, and then the clinical suspicion is P2, which I think is wrong here. Of course, it depends on circumstances, but if I can feel a lump in a patient, it can never be P2. And that's for one reason. This patient will go for a mammogram and ultrasound scan. It's common, not common, but it can happen that the imaging is normal. So what's next? Patient will be discharged. If I can feel a lump, I want to know what exactly is there.
This lump is, yes.
So fat necrosis, hematoma, palpable lump is P3 upward. So it can never be P2. Or we can miss really serious diagnoses and pathologies. So for this case, I think it is a P3. And then we can move forward to the imaging. from surgical point of view, like when I see this image is the mammogram, the first thing I notice from my side, of course, Dr. Wala explained and can you discuss it again, or
Yes,
Dr.
no
Wala,
problem.
your finding?
So this MLO view now showed increased density in the right upper breast with some distortion and dense lymph nodes. Then in the CC view, the same finding showed in the inner breast. There is lacking pectoralis in both breasts, which reduce the quality of the images. There is calcification, which is seen in the mammo monitors, not seen in this microcalcification. Increase the suspicion of the findings.
Okay. So, and what I noticed from my side point of view is that her right breast looks smaller than the left breast.
Yeah.
For me as a breast surgeon, this is very important because it can affect my decision later on what surgery this patient can have. Whether she is going
Smaller?
for breast cancer.
You said smaller?
The right breast looks smaller than the left, isn't it?
Can you go back to the MLO? Yeah, you're right. Yes.
Yeah, I'm not sure is it because of...
But the mammography, both MLO and CC are not an optimum one.
Yeah, correct.
For me, to be honest, most of the time this is right. Like if there is a, if you are like what we see on our images, like here in the presentation, maybe you zoomed in the image, but it's good time to discuss this issue because when I look at the mammogram, I really depend on the mammogram more than anything else. Even
You're
the
right.
MRI.
It looks smaller. I agree with you. It looks smaller on mammography, but we can be more accurate if the mammography is an optimum image. Sometimes minimal angulation can give more effect in the size of the breast and the appearance, even the appearance of the breast.
Okay, that's good point. Yeah, but like most of the time here anyway, like when they do the mammogram, almost always it's the same angulation because you can tell, isn't it, with the pectoral muscle and the end down there, the IM crease. But even if there is some difference angulation, it will not be as bad as the MRI. MRI is very deceiving because they are lying on their tummy and the breasts are going into a tube. Sometimes one of the breasts is just stick to the side of the tube or pressed on one side.
There is a recent intraoperative MRI with both supine and prone MRI that can help you. This is a recent one. You see, even
Okay.
they are doing in two position, in the same position that the patient lie for surgery. So can give more, more.
Of course, the patient will be examined anyway, and we will look into the discrepancy in size. But when we are in the MDT, because probably not all the surgeon met with the patient, our discussion will be based on the imaging we see, and then of course plans will change.
But sometimes, yes, sometimes even the tumor itself, sometimes the asymmetry is just a congenital one, and sometimes is related to the tumor. The tumor, if it is lobular, usually seen with lobular carcinoma, and in such cases, usually more extensive than this and associated with skin changes, resulting in shrunken breast appearance. But I think in this case, if it is smaller, it will be just يعني maybe
Technical.
previous surgery. If he has no previous surgery, it will be just a variant, a normal variant, more than just due to the underlying malignancy. But regarding this case, Dr. Wala, sorry, Dr. Wala, why you didn't say a mass regarding this case? You said just يعني asymmetry.
You can say a mass, but I can't see borders of the mass or very clear speculations. But yes, it could be a mass. But for me, I would say increased density with distortion, especially when the surgeon said P2 and I didn't do ultrasound. When I do ultrasound of the same case, I will change the description to mass. But up till now in the mammogram, I can say only distortion with associated increased density. But if you have other opinion, it is well respected, definitely.
Thank you very much. Thank you. Not just يعني I'm asking يعني, but yeah, from my يعني.
Because when the surgeon said P2,
no, even
we have a lot of.
I have been faced with this problem many times, as Dr. Ghassan said. Even the patient came to us for ultrasound, and يعني she said that she started, يعني she continued deny she has a serious problem, and she's telling she has trauma and she has so and so and so and so, and we found extensive cancer, sometimes involved the whole breast, and she still denies. You see, that is occur many times, يعني this problem. But even if he said it is B2, to me, in my opinion, I will go for a mass. Maybe I will be in a doubt in the MLO to some extent, but when I see the CC view, I will label it as a mass, as an irregular mass. I can see a convex border.
Okay.
With distortion, yes.
I don't know what happened, but I have a slide with the pathology results of the mass and the receptors, and I missed it. I keep looking in my phone about the case notes, and I didn't find it, but sorry for this mistake. This case missing the histology slide.
Okay. That's why we can guess later, depending on the treatment.
Most likely,
So,
ER/BR positive, HER2 negative, but I will include this in the presentation and send it in the group.
okay. Thank you. So since it's LAPC now, LABC, the cancer is 70 something, you said. She went for CT scan, which showed no metastasis. And then how many lymph nodes? 2 lymph nodes with cortical thickening. And then she went for neoadjuvant chemotherapy, and she had complete radiological response. Is that right?
Yes.
Yeah. So depend on that, she came back for surgery, and I understand they went for right mastectomy and sentinel node biopsy. Now the surgical options, most of the time now we are pushing more towards breast conservation, especially when patient has complete radiological response. The discussion between removing the footprint or just taking like a diagnostic excision of the area is still controversial. In every breast conference, there will be two teams with a debate of that, whether you take the full area or just part of it to prove that it is completely responded. And their argument, of course, is you can never be sure whether the response was patchy histologically And in that case, you might remove only an area with scarring only, like complete response, while leaving a disease, or leaving behind, or you need to remove the whole thing. But even if you are removing the footprint, of course, it's not wide local excision of the footprint. Like usually you don't need margin here. You just remove the footprint, excise the whole area. And in most of the cases, then our discussion with the patient will be either we do volume replacement or volume displacement, which means like volume displacement is to displace the breast tissue around to reorganize the breast tissue. And you can do that like just simple island flap, like moving the breast tissue to close the cavity, and that can work in small cancers. Or you do a bigger procedure, a level 1 mammoplasty, like a round block, you are just removing some of the skin and closing the cavity. Or level 2 mammoplasty, where you remove large amount of the breast tissue and do like a reduction. And there are many, many types. In this case, that's why I mentioned that her right breast is smaller. So if you are going for a reduction, in many places, you do it on both sides at the same time, but you need to take more from the left side. And it depends, of course, if the patient will be happy with much smaller breasts. But it is doable, especially in large breasts. You can do that. In smaller breasts, this case, the cancer is in the upper inner quadrant of her right breast. And if you are thinking of volume replacement of this big area, most of the time now we are doing the chest wall perforator flaps. In her case, the only perforator flap which can reach to the upper inner quadrant will be a TDAP, like using perforator from the thoracodorsal. So that's an option. Just to discuss with the patient's option, mastectomy is an option. We try to avoid it if possible. Breast conservation with or without oncoplastic procedure. Oncoplastic procedure can be volume displacement or volume replacement. This case probably went through that discussion, whether she chose to go for mastectomy or the surgeon decided, because also it depends on availability. Not every unit has oncoplastic services. So she went for mastectomy and sentinel node biopsy. And of course, the traditional way of doing this case is doing mastectomy and clearance, because she is known. That's the traditional, just doing clearance because we knew from the start that she has lymph node metastasis. Or some places will do targeted axillary dissection, which is the TAD, in which the biopsied lymph node must have been marked from the start, like at the time of the diagnosis. They take the biopsy from the lymph nodes and put a marker clip or whatever markers they use in that lymph node. If they reach complete radiological response like this one, then you do the TAD, in which you remove the biopsied lymph nodes with the sentinel node biopsies. If that's clear, no cancer, then people tend not to do anything more. Or now in the ethnic trial, they just want to prove that in complete radiological response, complete pathological response cases, no need for further treatment. Therefore, all patients with a T3 cancer like this one, from T1 to T3 and N1, so 1 to 3 lymph nodes involved, if the end of treatment imaging showed complete response, then they go for the breast procedure and sentinel node biopsy, at least 3 lymph nodes. If those found as clear, like complete pathological response, then patient either go for the full treatment, the usual like radiotherapy, or the dissection from the start, or the other pathway is not to do anything, and we keep an eye on them. And they want just to prove that this is like no further treatment in this case is not inferior to treating the axilla by dissection or radiotherapy.
What do you mean by footprint? The epicenter of the mass? or
footprint is
the size of the the mass itself or the area involved by the cancer itself.
yeah the initial area, the baseline area which was involved by the cancer, and now you can't see it at the end of treatment MRI scan. One team think that we need to remove the whole area, the footprint of the cancer. And other team think no need for that. All what you need to do is to prove that there is no remaining cancer. Me personally, I tend to remove the footprint until now. I'm not comfortable just to take a small area of it. But this discussion goes on in every meeting, and every team has their own argument.
How you can decide it after complete pathological response?
It is
No, you decide that after the complete
radiological response, I mean.
Radiological response, yeah. So when you do the MRI scan, end of treatment MRI, and you tell me that you can't see anything, it is complete radiological response. Of course, you have a clip marker from the start in that area.
Clip from the dimensions at the margins. It will be at the margins of the mass, initial mass, the clips, or at the center.
The clip of
one clip or multiple clips. I don't understand. I have no experience in this.
The clip of the biopsy, Dr. Rabab. So they will have the normal clip, which
for
is,
example, it was 5.5 centimeter. So you will clip the mass from each margins.
No.
So he could
Just
understand
one
that
clip.
Involve or what, or only the center.
You
the
mean
center is.
I think she is asking about the surgery markers for wide local excision, or you are asking about the marker clip after biopsy initially?
No, I'm asking how they could decide the footprint after complete pathological resolution. I have no experience in this area.
So that's by imagination. Like we look at your images, we discuss with the radiologist, and it's very important that before surgery, I always used to go, by the way, I moved from Sherwood Forest Hospital. I should have updated that. But when I was in Sherwood Forest, it's a smaller unit. I used to go before my theater always to the radiologist, and we discuss the imaging. Where is the clip, the marker clip, the initial one? Where is the marker, the current marker? We used to use wires, wire markers at Sherwood Forest till I left. So I discussed the wire marker with the radiologist and plan whereabout is the mass and how much I need to take from around the wire. I go like 2 centimeter medially, 1 centimeter laterally, superiorly, inferiorly. Now, intraoperatively, the area of the cancer usually is very scarred. You can still feel hard area, and you tend to remove that. If I'm doing a mammoplastic procedure like a reduction or chest wall perforated flap or volume replacement, it's easy to take more than what I need. And that's the beauty of the oncoplastic surgery. So I remove as much as I want and I replace that volume from the area.
But generally no need to take more than the footprint after complete radiological response. No need.
No need. But as you said, you can't be sure 100% that you are removing the area. It made life easier for us. If you are replacing that volume, you can take what you think adequate.
Okay. Now I understand. Thank you.
By tumor footprint, you actually mean tumor bed.
Yes, it's a tumor bed, yes.
Yeah, it's a tumor bed, yeah, Rabab. But you can only determine it by looking at pre-treatment radiology.
That's right.
He's 100% dependent on the radiologist and discussing it one-to-one with him to be able to know during surgery how much he needs to remove.
Yes, because sometimes the clip even
it's just
it's not
one marker.
the center of the mass.
Yeah.
Sometimes at the margin of the mass.
Yeah. So the clip is just to denote the area.
Yeah, you have got many variables because, as you said, we discussed the clip, whereabout is the clip
Yeah.
from the mass, and then when they put the marker for us, whether it's wire or a marking seed, then we discuss that as well, because not um, every time the wire will go through that clip, it will be away as well. So there are
Yeah.
many combinations that you need to work with, and therefore what I'm saying, I can remove as much as I want there to make sure I remove the clips, the wires, the footprint,
Yeah.
since I'm replacing that or I'm doing a reduction. But some patients might say, no, I want just simple procedure. I don't want any complicated, because they know risks can increase. And when you start to discuss with them the risks, even if it's minimal, some of them just get worried about that and tell you, no, I need just a simple procedure. In that case, you need to plan it really well to avoid the significant deformity which will happen.
So you have discussion before treatment, before starting neoadjuvant.
No,
Regarding
after.
the
No.
after,
Yeah.
you make it difficult for the radiologist. Okay.
I will tell you what is our department or what is our team doing. So if the patient is planned for wide local excision and the mass is non-palpable and it has complete radiological response and it is smaller than 2 centimeter, they will ask for maxid targeting the the um, the marker, the biopsy marker from the beginning. So when it is complete radiological response, most likely we are going with stereo guided maxid insertion. If there is
After or before?
Before.
after chemotherapy,
Uh-huh.
because
Because
complete
I understand that in some centers they are doing before, yes?
maxid, you mean, or
Yes,
or
yes. Yeah.
no, maxid should be just before surgery. We are not putting it before chemotherapy because maxid is always have complication of migration and problems with
Yeah. You put it you put it following the site of the biopsy marker.
If the biopsy marker was in the center of the lesion, for example, if it is a mass, because sometimes it is only DCIS with calcification.
Yeah.
So then if it is DCIS with calcification, they usually use bracketing wires.
Okay. So you will determine the margins or the extent of the calcification.
Yes.
But
Stereo guided.
regarding the asymmetry or mass, and usually the calcifications, it will be residual. Yani it will be
Yes.
there post neoadjuvant. But the problem is
هو الراجل قال لي خديها برا عشان تنجب وانا
asymmetry.
Could you please mute yourself? Could you mute yourself, please, Dr. Riham?
اسمع يخددوا
You can
I did mute them.
Yes.
You can
Okay.
proceed now, Dr. Ola. Sorry.
ايوه واصلي يا دكتورة ولاء.
So sometimes if the mass is more than 2 centimeter and it is bigger than 2 centimeter, most likely they will ask for bracketing wires, either by ultrasound if the mass is partially responding, so that we can see it on ultrasound, or stereo guided if it is complete response and they want to do wide local excision. If it is for mastectomy, they will not ask
complete.
for.
No. If it is complete and you do stereotactic, so you will imagine according to the previous, you see, pre-treatment, and you put the maxid, yes.
If it is less than 2 centimeter, yes, we put maxi.
If it is more, if it is more,
if it is more, they will ask for bracketing wires. They will give you the. We will have, most likely we will have ultrasound features of whatever the residual. If no residual, we will do mammogram And from the mammogram, we will decide with the surgeon which areas he want to bracket wire guided, stereo guided, and they will do it on the same day of surgery. So they will bring the lady in the morning for wire bracketing wires. They will discuss with you in front of the monitors which areas they want to bracket.
According to the previous pre-treatment image.
Yes.
Okay. Thank you. خدنا كتير. We
Now,
took too much
one thing about the mag
to
seed,
understand.
you need to put them following the end of treatment MRI because
Yes.
it's magnetic, so the whole breast will be a big black hole.
Yeah, right.
I cannot imagine, Dr. Qasim, I cannot imagine how come there is a group discussing that the tumor bed is not to be removed completely. I cannot understand how, because we know tumor does not respond the same, and the tumor can change and can have different types of cells, tumor cells in the same tumor. So the argument behind that, I cannot understand at all. That they don't want to, like as a surgeon, you don't want to remove the whole tumor bed.
Yeah, so you selected your team already. As I said, both of them has their arguments.
I cannot understand their argument. That's the
Now,
thing.
like they are selective in cases when they say you don't need to remove the full, like the excellent responders to the neoadjuvant chemotherapy, like the triple negative and HER2 positive, if the end of treatment is showing nothing at all, most of the time there is nothing. And they argue that the risk of leaving something behind is less devastating than the deformity that we leave patients with.
Okay.
But as I said, many surgeons they say that and they argue with that, but they don't do it. Like when they say we don't remove the footprint, they are actually removing large amount of tissue and showing scarring. But this actually it helps when you do your wide local excision, and then the histopathologist you tell us that there is no residual cancer. However, the scarring is reaching this margin. Do I need to go and take more or just leave it?
Yeah,
This
because of
this is this is where the discussion comes into view. Yeah, though most of the time we don't go back. Like we removed large amount of tissue, all of it is showing complete response. It's just scarring. Why do I need to go back and take more?
And sort of push into more scarring.
Yeah.
Okay, if I have a complete response and I can prove it without histopathology, then it's the case where I leave the patients alone and I just observe.
I couldn't hear you well. I think the sound went.
Yeah.
This would take us to the point where if you are convinced that the tumor has complete response, then you push the patient according to the type and of course the other circumstances into an observation, not doing anything, not doing surgery.
That's the future. And
Yeah.
it will be the radiologists who are doing like vacuum assisted excision, something like that to prove it is fully responded.
Okay. Yeah.
Cryotherapy is coming on the scene now.
But
Cryo,
cryotherapy.
yes. Yeah.
Mm-hmm. Yeah, many people say like the oncological breast surgery is going to vanish soon. Our role will be from that side is just to prove that there is nothing left. But soon enough, we won't need to do any surgery for that.
I don't think so. Because there are cases of advanced cancer and you need to do mastectomy. Then what is the plan? I don't think so. It's not like that. There will be change in practice, but it will not like completely go to one side. But there will be changes in the practice.
So
changes,
how many
yes.
advanced cases have you seen? We're not talking about Sudan or like
Yeah,
There are,
exactly.
lobular carcinoma always is a challenge. There are cases which are more than 5 centimeter or hold the breast. I just discussed last MDT yesterday. There was complete breast involvement. I will show you the image in the next meeting. And the lady is for mastectomy, and they are discussing. The lady will not be, will not accept because she always she even the mammogram itself she don't want it because there is a risk of cancer. She is 70 something, taking HRT for more than 10 years, and she don't want. So it is not. They will be just changes, Dr. Ghassan. It's not.
yeah, I'm not saying that we are useless. I'm just saying that there will not be that many cases. Like now, everyone with breast cancer will need operation.
Good, you will be
But in about,
relaxed.
sorry?
You
Yeah,
will be
no,
relaxed.
it's not my, yeah, it's not in my era. And then if that happen here, we can all go back home. So it's not happening soon, but that's the way because now the de-escalation, like the ethnic is trying to prove that there is no need to do anything.
Yeah.
To do what?
And the ethnic
Auxiliary.
trial, this lady went through ethnic trial. So, and she's going to the I mean, I think you said she's going to the doing nothing, just observing. So she did have 2 lymph nodes involved. Now no residual disease in the SMB, and those will be just followed, monitored for like 5 years to see if there is any recurrence. If no recurrence, they can prove that if the end of treatment MRI showed no residual disease in the breast or the axilla, you can only do SMB, no need for clearance. And when you do the SMB, if that showed nothing, you don't need to do anything more, no radiotherapy to the axilla or anything.
Yeah.
After that, it will be, and I can imagine, they will try to prove that no need for the SMB. You just do ultrasound guided biopsy, another core biopsy, and to prove that's not inferior to doing SMB. And that's the way things are going. That's why the surgical uh, treatment in many cases will not be needed anymore. It will be just to prove things.
De-escalation, yeah.
De-escalation, yeah, it's happening in everything.
Yeah.
But Dr. Ghassan, I'm doing a audit about avoid audit if you hear about it, which is the volume of the disease in the axilla determined by ultrasound core biopsy. So most of the 80% of the cases which has LB2 from the beginning come to have a malignant on sentinel lymph node biopsy. So core biopsy will not solve the problem of proving there is axillary involvement or not. So there will be a lot of debate and trials, but biopsy itself will not 100% prove exclusion of cancer in lymph node.
No.
You
So
see,
far.
because not always it is يعني the involvement of the lymph nodes, it might be from one afferent or 2 afferent from different sites and something like that. And they have to target the most or the highly suspicious region, and not always the highly suspicious region. It is the thickening region. Sometimes might related to the altered echogenicity or to the hilar distortion, because also it depends where exactly it deposits within the sinus. Is it subcapsular or deep near to the medulla? You see, it depends where exactly the metastatic cells deposited within the lymph node. Okay, accordingly, it will affect the lymph nodes. Sometimes, if you attend our lectures before, with Dr. Ramona, I demonstrate that that changes within the lymph node. The different appearance of morphological appearance of the lymph node related to the area where exactly the metastatic deposit occurs and how does it appear on radiology. And that is why the radiologist have to be aware about these morphological changes, and he has to target the most suspicious region, okay, to have a good result.
Which is not always the case, because most
Yes,
of the cases,
not always the case. Agree.
most
It
of
is
the
all
cases are symptomatic clinic, which is acute clinic and very busy clinic. 22 cases in a 4-hour clinic. You want to do biopsy of the breast and biopsy of another region in the breast itself, and then biopsy of the axilla, and you want to target the most abnormal lymph node, and you want to target the most abnormal area. You don't have the time to do all of this. So
yeah, that's why.
a lot of challenges, yeah.
Yeah, it is challenging. Yeah, it is challenging. Challenging. Okay, we can shift to the second case.
Okay. So second case is 80-year-old male, come with right breast and axillary lump, and he has previous lymphoma. So on examination, right lump query gynecomastia. However, the surgeon said it is a bit more nodular and there is degree of nipple distortion. So there are palpable bilateral axillary lymph nodes and neck nodes, and they want to make sure if it is a recurrence of lymphoma or it is related to the breast. So this was his mammogram, which is showing right.
Give it to one of the junior
Yes.
radiologists. Nihad is there, or she left? Nihad, are you there? No one of junior radiologists is available with us. Okay, شكله ما في حدا. No problem. We can proceed.
Okay, so do you want me to describe or anyone else in the?
من الموجودين. Anyone he want to take the case?
So there is a mass in the retroareolar region on the right breast with nipple retraction or involvement because there is thickening of the areola. So that has been biopsied. And the ultrasound of the same breast show a nodular hypoechoic irregular mass involving the nipple, and the axilla showed abnormal lymph nodes with cortical thickening. So needle core biopsy showed B5 non-specific type, at least grade 2, with perineural invasion. The right axilla is LB5. So CT no other involved areas. Right breast cancer with ipsilateral level 1 axillary lymph nodes. I don't want to go fast. Do you have any comments on the imaging before going to surgery?
Can you go back to the mammography?
Yes. Dr. Rabab?
There is also, yes, yeah, the mass, yes. And I observe this asymmetry. Sometimes this can be helpful. You see the vascularity in the ipsilateral breast is asymmetrically larger compared to the contralateral breast. If you are for the junior doctors, this is a straightforward mass. Yani. It has a convex border, it has a speculation and with nipple retraction and thickening and everything. But for the junior doctors, if she is in doubt, or if they are in doubt for is it gynecomastia or a mass, look for sometimes for the ancillary features. The ancillary feature here is the nipple retraction and thickening, as well also with gynecomastia, you don't expect to have asymmetric engorgement of the same breast or ipsilateral breast compared to the other side. And he
Yes.
has gynecomastia. Yeah, in the left breast he has small gynecomastia.
Yeah.
Okay.
So this is the post-surgery. This patient had mastectomy and axillary nodal dissection. I will go back to the image when the surgeon, Dr. Ghassan, wanted. So the pathology after mastectomy was tumor size 16 millimeter localized, grade 3, with DCIS, 2 millimeter from the skin, margin 3 millimeter deep, more than 5 millimeter elsewhere. Nodes 5 out of 22 positive. Level 1 and 2 are involved. There is macrometastasis with extracapsular spread. So tumor staging was T1N2A. Receptors ERBR positive, HER2 negative. And there is background of malignant calcifications. Genetic testing was negative. This patient went through adjuvant chemotherapy and endocrine therapy. So, and radiotherapy to the chest wall and axilla beyond the clips. Comments are open to other parties.
Can we see the lymph node ultrasound? This is the only involved lymph node, or there is another one?
There are multiple lymph nodes. I didn't bring all the images, but all similar appearance. If you have a history of lymphoma, you would be in doubt if you see the axilla, but I'm sorry I didn't bring, but it is the same appearance of this lymph node.
But I'm asking to look for the extracapsular extension. Here I can see the perinodal edema, but the extracapsular extension not frankly seen based on ultrasound. That is why I ask you.
It is after pathology, after excision.
Okay.
Not we can see it on imaging. I don't know that, Dr. Rabab. We can see extracapsular spread if it is just millimeters. I don't know that.
No, I ask you regarding this image. You see, there is no sign to suggest frank extracapsular extension based on this single selected. Yes. Do you agree with me? That's why I ask.
Yeah.
There is, I can report perinodal edema, but I cannot trace the suspicion of extracapsular extension based on this ultrasound.
Yes.
On imaging.
Agree.
Okay.
Dr. Hassan, do you want to say anything? Pathologist, everybody.
Dr. Hassan is going to comment, yeah? Your voice is not clear, Dr. Hassan.
Maybe he is mute. I can't see the...
Yeah.
Yes, sorry, I was mute, yeah. So I'm saying the case is a good case, and also highlight areas like first, also missing cancers in male, especially if they have what looks like bilateral gynecomastia. Because for now, like many protocols say, clinically when it's bilateral gynecomastia, you don't need to do imaging and you don't need to do any bloods or investigations. So you're reassuring patient and send them back to their GP. Of course, unless you have a red flag sign like nipple retraction in this one, or you can feel a lump there. But sometimes it's very small. I had a case with who came and he does have bilateral gynecomastia and no palpable lumps, but he did have a bloody nipple discharge, which is unusual for males.
Yeah.
And and the other worrying thing that he's known with bracket two gene, I think it was two. So usually for male with even a lump, we do ultrasound scan. And they did ultrasound scan, and there was nothing. So he was brought after 3 months for like a follow-up. On examination, I was able to express bloody nipple discharge, and I asked them to do if they can do a mammogram. We don't do when I was at Sherwood Forest Hospital. We don't do mammograms routinely for males. So I asked for a mammogram, and I actually showed them a piece of tissue paper with the blood in it, and they did it, and they could see the malignant looking lump. That's why we need to be careful in males. Examination, unilateral gynecomastia always need imaging and bloods if there is no clear cause of the gynecomastia. And then even if the imaging, if there is a red flag sign like this, retracted nipple, fixed mass, even if imaging is normal, then we need to go for freehand biopsy. And this also happened before. Freehand biopsy confirmed the breast cancer. Unfortunately, male are discriminated against in breast surgery. So we don't do full workup. Usually there's no clear guidelines for them.
Yes.
Mammogram-wise imaging, of course, all males go for mastectomy. There is no breast conservation for males, as far as I'm aware. So we do the mastectomy, and in this case, he had axillary node clearance. And following that, the adjuvant treatment, he went for chemotherapy, but also he is, as said here, he's eligible for abemaciclib, which CDK4/6 inhibitors. This is recently, like in the last years, started to be given in adjuvant setting, and the indication, I think, is for either you have N2, like more than 3 lymph nodes involved. I think he had more than 3 lymph nodes involved, right?
5 lymph nodes, I think. 5 out.
5. So
Yes.
from that only, he's eligible in ER/PR positive cancers. He's eligible for abemaciclib, and or N1 less than 3 lymph nodes, 1 to 3 lymph nodes. But I think grade 3, if they are grade 3, then they are also eligible. It will be very useful, honestly, if we have oncologists with us in these sessions.
Yeah,
Uh,
I want to
that
ask.
Yeah, that will give really, because I might be saying lies now.
But
So
you give us good information about oncology, but I need to have I have a lot of questions oncology wise.
yeah, it will be really useful.
Yeah.
And also, he is male breast cancer, they are eligible for genetic testing. So male breast cancer, they go for genetic testing. And it's mainly because if they are gene positive, like BRCA2 or BRCA1, then his
Their
first
families.
degree relatives need to be tested. Again, there is no guidelines for males with positive genetic tests, because in female, usually we offer them risk reduction surgery, other modalities like endocrine treatment, chemo prevention, lifestyle changes. But for male, you diagnose them. For the rest of the family, there is no guidance for them. You don't do anything because the risk is still maximum about 6%. So it's not that high. It is still within the normal population range, normal population risk range of female patients. So it doesn't need anything. It doesn't need monetary, like any female with 6% risk, lifetime risk of breast cancer is a normal population. She doesn't get anything extra. That's why males, when they are diagnosed, there is no guidance for nothing. No, we don't need to do anything for them. But like for the case I saw, the man is known with BRCA2 gene and diagnosed with breast cancer. We went into the dilemma. He is a high risk and he developed already breast cancer. Do we offer him risk reduction on the other side, or we leave it? Because there is no guidance for that. Eventually, we did do bilateral mastectomy in that guy. But I think we need a revolution for male. We
But
need
Dr.
equality.
Hassan, I have a question.
Mhm.
Usually male they don't have glandular tissue, and for genetic issues, most likely we target the glandular tissues because it is more suspicious for having a cancer. So is it beneficial to give mastectomy for a male who doesn't have any glandular?
Yeah, like if you've got a male patient known with gene mutation, but doesn't have problem like he hasn't developed breast cancer or anything like that, you don't need to do anything. And we do have a glandular tissue, it's just dormant. So when we do mastectomy, we do remove enough tissue. It's like a BRCA A, sometimes B, and for those with gynecomastia, you can even have C. So we do have a glandular tissue, but very dormant, and then we have the fatty tissue. With the gene, and that's why the risk of developing breast cancer, even with gene mutation, is very low in male, and that's because the few glandular tissue. They don't have as much glandular tissue as female.
Okay.
Dr. Ghassan, you said regarding gynecomastia, if it is bilateral, do you mean if it is palpable bilaterally? Yes?
Clinically, yes.
Because in my practice, most of the patient of male breast cancer I have seen, they have bilateral asymmetric gynecomastia. Most of them. I don't remember a case having just a unilateral breast cancer without having any tissue in the contralateral breast. And also I have seen one patient presented before in one of my lectures in last October having bilateral gynecomastia and ductectasia, and with microcalcifications proven to have DCIS, which is rare, extremely rare. But the patient had pituitary tumor.
Okay.
Mm.
No, like I agree when you said gynecomastia larger on one side. It can be, of course, gynecomastia, but when it's asymmetrical, then you need to do some imaging. I'm talking about clinically, patient came male, 70 something years of age on like tamsulosin or any, or he had hormonal treatment for the prostate. This patient, when they come to you and they have bilateral swelling in the breast and examination soft, like there is no nipple retraction, there is no palpable lumps, there is no asymmetry between the two sides. All what I need is just to reassure them it's gynecomastia. There is obvious cause and examination, nothing. But when you find the patient with no clear reason for gynecomastia, and it's either unilateral or asymmetrical, or they have something red flag sign, like a palpable lump, firm lump, not the gynecomastia is a rubbery one, like firm or hard lump, nipple retraction, ulceration, anything, any red flag sign, you will do your imaging. But of course, you might miss a pathology
but few
in males.
But generally, radiologically, gynecomastia, more than 90% of gynecomastia are asymmetric, like CILARC, early developing of breast in young girl is usually asymmetric. Also, gynecomastia, most of the gynecomastia are asymmetric.
Yeah, those are the one you see, because we send them to you for imaging because of the asymmetry or finding something. But we do see many patients with symmetrical gynecomastia.
Gynecomastia.
Most of the elderly, they do have symmetrical gynecomastia.
Mm-hmm.
That's very normal. Examination is normal, reassurance and discharge. And actually now, currently, even younger ages, like I don't know why, younger age, they do have bilateral gynecomastia. But for those, usually we do some bloods just to make sure the hormones, there is nothing, hormonal imbalance or any cause. But when we
Yeah.
send them to you for imaging, that usually means there is something odd, either asymmetry or palpable lump or anything else.
Yes, gynecomastia. We have seen gynecomastia in pubertal gynecomastia, and we have seen in elderly as a physiological gynecomastia and neonatal. But I think nowadays with the use of some hormones and these things, we can see it in 20s and 30s, something like that. This is unusual presentation. I have seen a couple of cases like this. They are receiving hormones and something like that.
Here in UK, it's very common in the athletes. They take anabolic steroids.
Yeah.
Anabolic steroids, which is testosterone, it is converted usually in the liver to estrogen. So it's very common here in the 20s because they do use them to get bulky muscle quickly.
Yes,
And they
yes,
come
that
with
is right.
gynecomastia. But again, usually it is bilateral. So those most of the time are eligible for just hormonal check. If they told me that they are using the anabolic steroids, I wouldn't even bother with the blood check. It's just reassurance, discharge, and advise them to stop. Sometimes we use tamoxifen for 6 to 9 months
Antagonize the estrogen.
to block, the estrogen. But
Okay.
that's the difference. So in this case, without the palpable lump, it can be missed. But I think it's good that it was detected and treated. And but the most important bit which we are missing in Sudan is the genetic testing. Like any male with breast cancer, they should go for genetic testing to protect the rest of the family, their daughters, their sisters.
They send it outside, I think. When there was Sudan, they take the samples and send it to Germany, and that's what I know.
But selective cases because it is expensive,
Yeah.
Not all they can afford it.
Yeah.
So this case was in Sudan.
No.
Okay. Yes.
But in Sudan, I know some people do that. Take the samples and send it outside.
Okay.
For the one who can afford it. So case 3 is 78-year-old. Do you want me to go?
Yeah, continue.
So case 3 is 78-year-old female. Come with left breast hard lump at 3 o'clock position with skin tethering and no previous surgeries. So this is her mammogram. You want me to go and...
Yeah, straightforward by 5.
Yes. It's speculation and skin tethering.
Yeah.
And this is her ultrasound, and there is calcification as well. And very dense shadowing with surrounding edema. So that her axillary scan, which is showing multiple lymph nodes with cortical thickening. And histology was invasive carcinoma, B5B, LB5 for the axilla. Receptors were ER, BR positive, HER2 negative. And staging was T4, N1, M0. Metastatic workup negative. Plan was wide local excision and axillary nodal clearance. This is her surgery.
Very long spicules in the
Yeah.
specimen. Yeah.
So histology was invasive carcinoma, non-specific type, grade 2. So staging after surgery is T3P2M1. Tumor size is 27, including DCIS, 5 nodes from 21 positive, with macrometastasis and extracapsular spread as well, similar to that case. Plan was chemotherapy, adjuvant chemotherapy, radiotherapy, endocrine therapy, and abiciclib. I don't know how to say it. And adjuvant biphosphonates for you, Dr. Ghassan.
Before Dr. Ghassan, go back for the lymph node. This is yani, again, here very subtle. Yeah, one lymph node showing extracapsular,
It's lymph
but
node.
very focal, very focal. You
Yeah.
see, the one on the right, you see, this inferior extension, like the ductal extension, this one. This is
Use
the
the
afferent.
marker, Dr. Rabak.
Huh?
You can use the marker on the screen. We can't see your.
From where? From where I can use the marker? I don't know.
There is marker here.
This
It
here,
doesn't annotate.
this one,
Mhm.
not annotated for me. But
I
the
can give
one
you.
on the right, the rounded one on the right.
I can give you. Just give me the. I want to
Oh.
give you the control. You can give her the control, Dr. Anauras.
No. It will take time. Okay, just this one, yeah.
Sorry.
Let me check.
The one on the right, the image on the right, the rounded lymph node.
Yes.
It is very subtle. Yani this extracapsular extension. So we have to be cautious. We have to be cautious. You see, and even yani subtle features, we have to mention it. We should not ignore it. From your cases, this is a teaching point. Now you have two cases with very subtle extracapsular. One by imaging, no obvious extracapsular extension, only perinodal edema. Yes, that is the one. Yeah, this is extracapsular extension. Okay.
Okay.
It can be passed, yani easily missed.
We don't
Okay.
usually report it.
Huh?
You that? We don't
I
usually
used to,
report that.
I used to report it. For me, I used to report it.
We
But
will.
now,
I will add it in my
but
template.
usually you have seen extracapsular extension when the lymph node is yani sizable with more thick asymmetric cortical yani thickening, not like this. Rarely, I have some cases, but very few cases with extracapsular extension and the lymph node is still small. But from your cases, we have to be more cautious. Okay, go ahead.
So if we go to the mammogram, again, in this case, like this looks like, what's the size of the lump?
27.
27. So looking at the, but even in the mammogram from the start, if you told me it's 27, or that means this is a very big breast. So this will be BRCA G or F. And for this lady, I would definitely offer her some form of mammoplasty, even though she is 70 something. But here it's not about the cosmetic. This is about radiotherapy. Like if we are doing breast conservation and she's going to get radiotherapy. For a huge breast, that means you are covering big area of radiotherapy. And that side effects then and risk affecting the whole skin, and they can struggle with that afterward. Therefore, giving them a smaller breast, decent shape and size, can help them, first of all, to minimize the deformity, and also help in the adjuvant treatment, the radiotherapy, to minimize the side effects and struggling with the effect on the skin in a big breast. Now it's in the upper outer quadrant, and we need to remove that skin. So I can either offer a wise pattern, but change the shape of my the wise pattern. Is it okay if I show pictures
Yes, of course.
here?
You can stop share. I will stop share. You take
I
the
can look. Just let me find some cases in my um, just to give you idea about how we do the wise pattern. Or let's see if I can find some cases here.
بقى نفهم أكتر. أيوة أفضل.
I don't think I have the marking, but
الباثولوجي طلع السايز كم يا ولا
27.
الباثولوجي
أيوة 27.
so
ما معاه DCIS
معاه DCIS.
بس كويس. لأنه 27 ده الانفيزيف بس في الماموجرافي، لأنه معاها في long spicule ماشي على going toward the nipple suspicious of associated DCIS ductal extension of DCIS. وكنت عايزة أسأل برضه I want to ask Mr. Ghassan in such case what they have to do, and shall we report it for them or not important?
They usually ask us not to include the speculation in the measurements because they find it after surgery not included in the.
yeah, it will make us excise more unnecessarily. So sharing is not turned on. I just sent you
But
a request.
I will allow.
I'll tell you something, Dr. Mr. Ghassan. In my practice, I depend on something, okay, on ultrasound. On mammography, depend on associated calcifications and distortion and such things. On ultrasound, depend on the spicule itself. If it is thick and hypo and central hypoechoic region, I consider it part of the mass. Okay. If it is just very thin, okay, just consider it as a reaction. I will not include it. But if it is relatively thick, I will include it in my measurement, and it is proven to be part of the lesions.
Oh, okay, that's interesting. And it's always helpful because when we do the excision, then we look, we take faxitron, like X-ray of the specimen. And it will always be helpful if we have a radiologist, because we see those speculation. Sometimes we take shaves and it comes out like nothing, and sometimes we leave it behind, and then we are told it's extending up to there. Therefore, it's a radiologist is needed.
Yeah, if is most of the time are desmoplastic reaction, fibrotic. Okay, يعني fibrotic effect or desmoplastic reaction, but it depends. يعني sometimes these within fibrotic close to the mass itself, there is some extension of the tumor within these spicules. I have seen some cases like that. So if I omitted the whole spicule, omitted from the measurement, and I might left some of the tumor mass.
Just want to share again. So can you see the image?
Yes.
Yeah, so I showed this is the racket handle technique or of a mammoplasty or tennis racket. Like this lady with the skin involvement, because we need to remove the skin, that can help, because in this case, that skin is going to go, that triangle of skin, and this area around the nipple and areola. So when we close that joint to this, and this will reduce the size of the envelope, and it will move the nipple that way because we are taking more from this side.
You'll make a
Moving
lift
it that,
for the breast, yeah. You will lift
sorry?
the breast up. You will lift, it will lift
Yeah,
the breast up.
it will lift the breast a little bit and reduce the envelope. So when we remove the cancer with the skin and close that, it will give her a little bit lifted, a little bit smaller, but not significantly. So it's not like a proper wise pattern technique where we do a proper lift. Because this lady is elderly and risk of complications, skin necrosis, this will be a good option for her. And even it can be done only on one side because it will not lift the breast that much. And it's very normal to have a little bit smaller breast than the other one. I can show you the intraoperative if you are not blood scared. So that's the idea. This is marked with a wire. Removing that skin, de-epithelialization, just removing the epidermis because we want to keep the blood supply here. And then here, that's the cancer removed with the skin. And after that, we just close everything together. And that's so it is a little bit lifted, smaller, and the nipple centralized in there. So that can be a good option in this lady. Okay, you can share again, Dr. Wala. And following that, as you said, because 5 lymph nodes, she is for chemotherapy, abemaciclib again, and radiotherapy. Bisphosphonate now is part of the treatment for 3 years. Bisphosphonate is given for postmenopausal with NPI above 3.4. Or if she had chemotherapy, like if it's triple negative.
Okay. So
But
any triple,
that's standard here, yeah. Chemotherapy, radiotherapy, abemaciclib, endocrine treatment, and bisphosphonate.
so case 4 is 29-year-old female, came to the two-weight clinic with left upper outer quadrant mass. So her first image on the left side showing 32 millimeter lobulated mass in the upper inner left breast. And that was biopsied, and I will talk about this later, if you allow me. So that was biopsied, and it came as B3 lesion, spindle cell lesion. So the lady has been offered to have surgery, and she didn't show up. Then after 2 months, so that was October 2024, and this was February 2025. So her mass show rapid increase in size up to 87 millimeter, and she came with heaviness and increasing the breast size up to this extent. Then because her mass has rapid increase in size, they suggest to do CT scan for staging before going to surgery. So staging show no, sorry, excuse me. So her CT scan show no metastasis. And after surgery, that was her pathology, which is malignant phylloid tumor. She did extended left mastectomy, and it was 30 centimeter tumor, completely excised, deep margin 2 millimeters. So the plan was to consider adjuvant radiotherapy due to closed deep margin. And there was a new right-sided sarcoma, which is seen as some nodules. It's not very well seen here, but if I have all the CT, there are multiple nodules which are enhancing on this CT scan. And I remember I discussed this case in the MDT before sending this patient to the sarcoma unit. This patient didn't have surgeon in our department. She sent to sarcoma unit. And I tell them there are enhancing nodules in the right breast, and they tell me they are so well defined and they are not our concern now. So after that, they did for her, because they find it malignant phylloid on the other side. They did biopsy to the right side, and it comes as another sarcomatous change in the right breast. She's only 29 years old. And sarcomas are, as usually, are more in young age. So anyone want to add anything here? Do you want me to start from this? Hello?
Yes, with you. Yeah.
So
interesting. دي
Yes.
طبعا usually the challenging area. Many times you see the patient, young ladies, presented with a parallel mass, though there are lobulation and focal area of indistinction. So it is BIRAT 4, not BIRAT 3. But sometimes core biopsy doesn't show directly phylloides, showing fibroepithelial tumors. The surgeon comes to us asking, would you think it is phylloides or fibroadenoma? Shall we go for this or that? This is a common scenario with us, in my experience.
It is
Dr.
very sad story, to be honest.
Huh?
It is very sad story. This young lady. Now,
But it is not,
fibroepithelial. Yeah.
is it common to have bilateral malignant phylloides?
I don't think so. I'm not sure, to be honest, because whenever we see phylloides, even borderline, usually we immediately ask for input from sarcoma team, because it's not a breast cancer or pathology. It's just happened to be in the breast. Now we are trying here in UK to come up with guidelines. I was just looking for the suggested ones, which now we start to work with it. But she came with a lump, and the biopsy was indeterminate B3 lesion. As Dr. Wala knows, we have like clear guidelines for B3 lesions. Fibroepithelial lesion, specifically fibroepithelial or papillary lesion with atypia, are for diagnostic excision, surgical diagnostic excision. So ideally, this lady should have gone for the diagnostic excision, but she didn't come, you said, right? She
had
DNA'd.
a plan with ultrasound maxid guided excision. It wasn't very well, it's not palpated. And the other thing, there was other multiple fibroadenomas. So they want to do maxid for the lesion, which is irregular. and she refused surgery and she didn't show up, and then she come back with this massive aggressive size increasement.
Regarding
Yeah.
surgery, Mr. Ghassan, if it
Mm.
is B3 or fibroepithelial, you will consider it as phylloides and you will go for wide local excision or as fibroadenoma.
Like when it's B3, when we go
Mm.
for diagnostic excision, it's lumpectomy. If they told us like they are really suspicious, like it's not B3, like B4, something of malignant phylloides, because even benign phylloides is like fibroadenoma. So probably this lady probably would have gone for just lumpectomy, like the MAC guided lumpectomy. Usually with phylloides, you will feel like intraoperatively to try and remove the whole, because fibroadenoma you can just with a finger pick it up if you are
Mm.
in the
That's
right
Mm.
plane.
yeah,
Mm.
But for phylloides, because they have these small extensions,
yeah.
Mm.
you won't be able to do that, and you will end using diathermy. So you will end removing it with some
Would like.
margin.
Mm. Mm.
But if I can show you the current guideline, if I can share this, just one sec.
I have been faced with many times cases like that. The surgeon back to us in radiology asking, what do you suggest? The pathology borderline. What do you suggest radiologically going toward which one? Is it a fibroadenoma going toward fibroadenoma or phylloides?
Yeah. So when they say the name like cellular fibroadenoma or benign phylloides, we just do lumpectomy. They still B3 lesion. So we just do lumpectomy. Now after the lumpectomy, when they come and tell us if it's benign phylloides, this is the guidelines. You don't really need much margin with it. So just aim for complete excision with capsule intact. So like fibroadenoma, if it's broken, then yeah, you have higher risk of recurrence, but it is still benign. So most of the time you don't need to go back there. Now, if it's borderline, you aim for 5 millimeters of margin, and then just consideration of radiotherapy if the margins are close. Mastectomy, of course, this one, if the patient comes with that much like huge lump, you'll need to do a mastectomy. There is no, and then you'll consider also some adjuvant. But what I want to show is mainly the malignant ones. So for malignant phylloides, the aim is for 10 millimeter usually. But this new suggested guidelines is say aim for 5 millimeters and re-excision for less than 3 if it's malignant phylloides. I think yours posteriorly was 2 millimeters. With mastectomy, you can't take more, so you don't need to take the muscle, but you will consider adjuvant therapy as well for close margin or for large tumors, and then they go for surveillance. Still, this is not approved. It's just suggested. Many units are trying to come up with guidelines. But for this patient, honestly, like B3, all B3 need to go for diagnostic excision. Usually here, Dr. Wala will do for us the vacuum-assisted excision, except for those, the fibroepithelial or papillary lesion with atypia. For those, we go for surgical excision. Some of the patients might need, again, oncoplastic procedures. If the lump is huge or recurrent, like if they had it removed before and it recurred, but we don't go from the start for oncoplastic procedure because usually if it's benign, it's just pushing the tissue. and the tissue will fill the space again once the lump is removed. But of course, if you are going to remove it with margin, that is a deformity, and you need to think of something to fill that gap.
I have seen more sad case in Sudan. 18-year-old presented like this 3 times with recurrent phylloides infiltrating the chest wall, and in the last time even infiltrating not only the chest wall but the pleura and the lung local extension.
Yeah, they can be aggressive, to be honest, and that's why people trying to come up with the guidelines for the diagnosis mainly. And we do refer them to the sarcoma team, so they look after them. We don't look after them. Once it's malignant phylloides, we don't have much role in the treatment.
Well, you are treating the benign and borderline?
Yeah, so these are, we excise them. For borderline, we do ask advice from the sarcoma team, and then we do the follow-up, like with 6, in some units, just annual mammograms for above 40 patients, and some is just clinical examinations. And now in this guidelines suggested to be 6 monthly clinical examination, and I think annual imaging.
I have the guidelines. If you, I include a teaching point on this case. If you want it, I can share it.
Yeah, sure.
Yeah, sure.
So from literature, I find this. So like initial follow-up should be after adjuvant radiotherapy. This malignant phylloid need adjuvant radiotherapy due to closed deep margin. And she need initial follow-up 3 to 6 months, clinical review, breast and chest wall ultrasound plus mammogram, plus or minus mammogram. Although they are young, but it is included in the literature. Ongoing surveillance plan.
Justified, yes. Malignancy.
Yes.
Malignant justified mammogram, yeah.
So ongoing surveillance plan imaging every 6 to 12 months for the first 2 years, and then annual for long term. So those similar to the high risk screening. And also recurrence risk counseling, like risk of local recurrence, 30 to 40% of malignant subtype will have local recurrence. So that is, we already have discussed it. I can go.
I think we can stop here.
Okay.
Or what do you think? We can continue. Do you have more cases?
So I have 3 more cases, but I think time is.
Yeah.
Yeah. I didn't even pray Asr.
Yeah, me too, I think.
Yeah.
No, we didn't.
Can you continue next Saturday? Give us these 3 cases, or difficult for you, Mr. Ghassan and Dr. Wala?
I don't remember. I don't know my agenda. I don't know what
Sure.
Okay. Yes.
I usually have many things in Saturdays, but I don't check
Yeah,
my.
if
السدر-
because next month you will not cover the MDT meeting. Dr. Rahiba is going to cover. You said you are on vacation. But if you have chance next Saturday, we will be happy to continue. Especially you have the pregnant cases also.
Yeah.
Forget to bring.
No, I bring one of them. I bring one of them. I have already, they reached the last night, so I bring it for you. And the other one not yet finished her
But
treatment.
if the other group they want to continue, I'll excuse you. to give me permission that I could not continue with you after this time. You see, it is too late
Yes.
and it will be difficult for me to
Mm.
stay more than this.
Yes, me too. I have other things to do, and we didn't pray. Not me, not Mr. Ghassan. Last.
You can add that case to next month, even if it's presented by anyone. It's because breast cancer with pregnancy is really, really, really interesting cases.
Is
Usually,
it difficult?
very,
I
very.
am asking you, yani, if you can give us 1 hour, 3 cases, 1 or 1.5 hour, okay, next Saturday, it will be good for us. If you have commitment, no problem.
I'm not sure, to be honest. As Dr.
Okay.
Wala said, Saturday most of the,
Just give
يعني
us
أنا الليلة
feedback.
أنا
Give
بالمناسبة
feedback.
أنا
let us
presenting من
let,
أنا ما في بيتنا
let us
أنا
just give you the chance to
no
check
problem.
your schedules, and
أيوة
then
أيوة يعني
yeah
نديكم فرصة to check your schedule, and if you are you can, it will be good. If you cannot,
خلاص
thank you very
خلاص
much.
if
بس
not, then
يكون
we can postpone date for other months inshallah اللي قدام
خلاص بس قريب
if
من
it's not
السبت عشان
possible.
نكون
Yeah.
بنعرف الوقت ده، لأنه هسه أنا وافقت على الام دي تي ده، التزمت به، لكن بعد ذاك عندنا شباب دفعاتنا جو من برا. أنا هسه لما أنت ضربت لي دكتورة ولا كنت ماسك الشيء تحت
لا حول.
فشغال بشوي،
طيب
فهسه
لو قلت
فولتوا عليه الشيء، طبعا أنا ما
خلاص
كنت
لو
امشي
معه.
امشي الحق لك قطعتين.
ما
كنا
خلاص
أجلنا
خربت حتكون بردت ذاتها بعد ده وضربوا الحتة السمحة.
والله بالك
فالحاجات دي
يعملوا
بيحصل
لك نيو
شنو؟
باتش يعملوا لك نيو باتش.
الحاجات بتحصل فجأة، يوم
So
السبت دي بتحصل فجأة.
لا
yes
لو قلت
فقريب
لنا
yes
لو قلت لنا يا دكتور يا مستر غسان كنا أجلنا لك، يعني عادي ما في مشكلة.
ده لا معقولة، بس لا ما قدر ده يعني.
لا والله عادي والله، ما
طيب
المسألة so
طيب
friendly يعني.
نخلي
فما
مستر
ما
غسان عشان هنا. any question from the audience? Any question from the audience to Mr. Ghassan and Dr. Wala?
You can ask everybody. This is your chance.
التيتشين بوينت يا شباب تنتبهوا عندها التو كيسز، very subtle extracapsular extension. Even if you look for the lymph node, you might pass it as unremarkable, but it is metastatic and even with extracapsular extension. Look for these lymph nodes. That is why
So if
we learn a lot from these MDTs and from the case discussion of these cases. Okay, thank you very much.
Thank you. Very interesting case.
Okay.
Dr. Wala and Mr.
If
Ghassan.
there's no further questions, we will conclude today's meeting. Yeah, so thank you very much, Dr. Wala and Mr. Ghassan, and the honorable members of the MDT team for sharing your valuable insights with us today. And we appreciate your participation and look forward to welcome you, inshallah, and the respectful audience in our future activities, inshallah, bismillah, next Saturday. Thank you and have a lovely evening, all of you.
Thank you very much. Thank you. We enjoy.
Thank you.
Thank you.
For everyone.